years after research started, the first vaccine against dengue became available and is approved in some dengue endemic areas, including the Philippines. However, the vaccine only provides transient protection. Secondary infection, which is associated with an increased risk of severe disease, still remains a challenge for dengue vaccine development. To our judges, the faculty of the Department of Medical Physiology, fellow students, guests, good afternoon. I am Patricia G. Bernardo, and on behalf of Group 3, Section C, I present to you a case of dengue shock syndrome complicated by type 1 diabetes mellitus. A 17-year-old girl was brought to the ER due to onset of chest pain, shortness of breath with coarse trails, and low blood pressure. Progressive cardiomegaly, very high heart haste, and congestion over bilateral lower lung fields were detected. Assessment of the heart revealed ST segment depression, global hypokinesis, and decreased left ventricular ejection fraction. Her troponin I and pancreatic enzymes were both elevated. On history taking, the patient previously consulted because of fever, chills, headache, retroorbital pain, sore throat, and myalgia, and was diagnosed and treated for respiratory infection. 3 days after that, the patient was admitted due to complaints of epigastric pain, on and off epistaxis, general body malaise, and swelling of both legs. She also had diarrhea, poor appetite, and severe hemorrhagic tendencies. Upon examination, she was anxious and dyspneic with mild pallor and generalized erythematous blanching of the skin. Her BP was 110/85, and she was tachycardic with a pulse rate of 142 beats per minute. She had positive multiple peticate and tourniquet tests on all extremities. Initial lab examination revealed elevated hematocrit and liver enzymes, thrombocytopenia, and hypoalbuminemia. 1 hour after admission, she developed shock with a BP of 95/80 and a pulse rate of 180 beats per minute. At this point, patient history led us to suspect dengue infection. Although hemorrhage is not uncommon in dengue fever, severe hemorrhagic symptoms exhibited by the patient led us to suspect a more severe form of the disease called dengue hemorrhagic fever or dengue shock syndrome. When dengue virus is injected into the bloodstream, cell-mediated immunity is activated to kill the virus-infected cells such as platelets, endothelial cells, and hepatocytes. Humoral immunity, on the other hand, neutralizes the virus by producing antibodies. This immune response leads to the following symptoms presented by the patient. In secondary infections, severe disease develops when existing antibodies fail to neutralize the virus, resulting to increased viral entry into macrophages and allowing unchecked viral replication with higher viral titers and increased cytokine production. Vasoactive mediators such as histamine, leukotrienes, prostaglandins, and nitric oxide are secreted, which mediate cytoskeletal changes and apoptosis in endothelial cells. Endothelial cell dysfunction causes plasma proteins, particularly albumin, to escape into the extravascular compartment, increasing the interstitial oncotic pressure that eventually leads to increased vascular permeability and plasma leakage, the hallmarks of DHF. Hemoconcentration, manifested as elevated hematocrit, result from intravascular plasma loss. Cytokine-mediated endothelial cell dysfunction, thrombocytopenia, and platelet dysfunction result in disruption of vascular integrity and increased capillary fragility, leading to hemorrhagic symptoms. Direct viral damage to the hepatocytes cause necrosis of liver cells and release of liver enzymes such as ALT, AST, and GGT into the serum. Acute liver dysfunction also leads to reduced synthesis of procoagulant factors, which contribute to the hemorrhagic tendencies. Plasma leakage eventually results in an acute decrease in the intravascular volume, decreasing the mean systemic filling pressure, blood pressure, and tissue perfusion, presenting as general body malaise, mild pallor, erythematous blanching of the skin, and disorientation. Reduced mean arterial pressure reduces the firing of the viral receptors, releasing the SNS from inhibition. Systemic vasoconstriction and increased heart rate and strength of contraction follows, in attempt to increase the systolic blood pressure. Concurrently, venoconstriction increases the preload and end-diastolic pressure. These two responses lead to the narrowing of pulse pressure associated with VHF. Despite these compensatory mechanisms, increased vascular permeability prevails, leading to hypovolemia and shock. In response, the different body systems work together to conserve the effective circulating volume. First, the extracellular osmolarity is increased by increasing blood glucose through synergistic actions of epinephrine, ACTH, and glucagon. Second, vasoconstrictors such as norepinephrine, angiotensin II, vasopressin, endothelin-1, and thromboxane A2 cause arteriolar constriction to decrease hydrostatic pressure, leading to net fluid reabsorption. SNS increases the afferent arteriolar resistance, which results to decreased renal blood flow and GFR that activate the RAAS, causing vasoconstriction, and salt and water conservation. The rise in extracellular fluid osmolarity and low arterial pressure cause release of ATH, promoting greater water reabsorption and excretion of concentrated urine. Prolonged reduction in the RBF, as well as direct viral toxicity to the renal parenchyma, eventually leads to acute kidney injury. This leads to impairment of reabsorption and excretion of electrolytes and metabolic byproducts such as creatinine and urea. Furthermore, alteration of the integrity of the glomerular membrane leads to the presence of sugar, ketone, RBC casts, and protein in the urine. In hypovolemia, impaired interstitial transport of oxygen and nutrients to the cell lead to mitochondrial dysfunction and uncoupling of oxidative phosphorylation, causing a shift to anaerobic glycolysis. Hydrogen ions, lactate, and other metabolic byproducts accumulate and contribute to metabolic acidosis. Acidosis stimulates the respiratory center via the chemoreceptor reflex to increase rate and depth of respiration to wash out the carbon dioxide and indirectly correct the acidosis. If these compensatory mechanisms fail to correct the problem, prolonged hypotension and another cycle of shock occurs. Back to the ER, the persistence of hemoconcentration and thrombocytopenia provoked the doctors to transfer our patient to the district hospital. She was given the following to replace fluid loss and to maintain electrolyte balance. At the district hospital, the patient was in mild respiratory distress, severely dehydrated, with dryness of the skin and sunken eyeballs. Labs showed consistently elevated blood glucose and persistent metabolic acidosis. Re-evaluation of the patient revealed history of polyuria, nocturia, polydipsia, and polyphagia in the past month. These symptoms, as well as her family history, led us to suspect type 1 diabetes mellitus. The absence of insulin in type 1 DM decreases the glucose uptake into the muscle and liver tissues, hence hyperglycemia is manifested. In the absence of glucose, her body tissues are geared into a catabolic state where glucose stores are mobilized and stored triglycerides are broken down into fatty acids, which are eventually oxidized to ketone acids accumulating in the blood and depleting bicarbonates, resulting to a condition called diabetic ketoacidosis. Hyperglycemia affects the kidneys by increasing the osmolarity of the tubular fluid, and osmotic diuresis ensues, manifested in the patient as polyuria and nocturia. This leads to volume contraction and dehydration, which exacerbates the hypovolemia. The patient was managed by continuous fluid resuscitation and IV insulin. She was stabilized on the third day of admission. As presented earlier, the most recent symptoms manifested are the following. These cardiac symptoms have resulted from direct viral toxicity to the myocardium and pericardium, leading to inflammation and necrosis, which releases troponin I. Myocardial conductivity decreases, which reduces stroke volume and cardiac output, and eventually decreases the mean arterial pressure and left ventricular ejection fraction. Myocardial hypoxia and ischemia follow, presenting as ST segment depression and leading to buildup of lactate, which caused the patient's chest pain. Hypoxia also results to the weakness of the heart muscles and its walls, hence the global hypokinesia revealed in the echocardiogram. Similarly, the acute pancreatitis revealed in the MRI and subsequent release of pancreatic enzymes resulted from direct pancreatic acinar injury due to viral invasion and systemic hypotension. Diffuse pulmonary capillary endothelial and alveolar injuries also allow proteins and fluids into the alveoli, resulting to non-cardiogenic pulmonary edema seen in the radiographs as perihilar case and congestion on bilateral lower lung fields. Pulmonary edema increases the surface tension and leads to consumption and depletion of surfactants. These increase the alveolar collapse pressure and reduce lung compliance, resulting to increased work of breathing. Perfusion of hypoventilated and non-ventilated alveoli increases the dead space, resulting to hypoxemia. The patient was managed with oxygen supplement, IV albumin, digoxin, and furosemide. On the 10th hospital day, her vital signs were normal. She was discharged on the 15th day. 1 month after discharge, no abnormal findings were seen in the patient. Ladies and gentlemen, please remember that all this resulted from one mosquito bite. The Philippines, in partnership with other countries and the World Health Organization, targets to end the epidemics of neglected tropical diseases by the year 2030. We hope this creates steers in each of us the concern to join in the collective effort towards the attainment of the goal. Once again, this is a case of dengue shock syndrome complicated by type 1 diabetes mellitus. Thank you and good afternoon.